first of all, thank you for everyone to joining us on this cloudy day. And we are very happy today to present a very important program on recognizing and managing autism of children in the pediatric and primary care environment. Okay, so my name is Marie McPherson, and I'm the director of the program for quality improvement and solution for behavioral health at the University of South Florida. We have a very important speaker today, Dr. Saundra Stock. She's a professor at the University of South Florida in the Department of Psychiatry and Behavioral Neurosciences. Dr. Stock served as a program director for USF Child and Adolescent Psychiatry Fellowship Program for 18 years, and is currently the Child Psychiatry Division Chief. Dr. Stock is an active member of the American Academy of Child and Adolescent Psychiatry, serving on the Committee for Continuing Medical Education. So we're very pleased to have a very talented and very expert in child and adolescent psychiatry, and especially for children with autism disorder. So Dr. Stock, here we go, please.
Okay, thanks, Mary. So we're going to talk the request was to talk about autism and some commonly associated problematic behaviors. So try to make this to have plenty of time at the end for questions. So you can feel free to put some questions in the chat if you want to while I'm talking. I'll try to make sure we've got time at the end for questions. I'm not sure if you guys have access to the chat. If you don't, you can always raise your hand electronically or unmute. So I do disclosures. I do serve on ACAP's, the American Academy of Child and Adolescent Psychiatry's CME committee, and definitely there is information on this talk that is not that is about using medications for non-FDA approved uses. So, just starting at the beginning, under DSM-5, we have two criteria: criteria A and criteria B for autism. Kids who have autism need to have all three of criteria A, which is deficits in social and emotional reciprocity, kind of the back and forth of showing interest, conversations, interest. They need to have deficits in nonverbal communication and deficits in relationships, deficits developing, maintaining, and understanding relationships. They need to have all three of those, and they need to have at least two of criteria B. Criteria B is stereotyped repetitive movements, repetitive speech, or repetitive use of objects. It can be insistence on sameness or very ritualized patterns. It can be restricted interests that are abnormal in their focus or abnormal in such as, toilets, vacuum cleaners, air conditioning, or abnormal in their intensity, like very intensely focused on trains, dinosaurs, whatever. And they might have sensory issues, either hypo or hypersensitivity, right? So you have to have all of criteria A with the deficits in social and emotional reciprocity, and criteria B. See a lot of understand that these are not exclusive to kids with autism, that, there are plenty of children that have anxiety disorders or can be part of normal development to have some stereotype behaviors. So, I see lots of kids that have anxiety that have an overlap in criteria B, and you really want to know the core of autism is this deficit in social and emotional reciprocity. That's really what you want to be paying attention to. Screening for autism, at your 12-month well child check, there's many relevant items on that related to autism, like is the child babbling? Is the child using gestures? Do they wave bye-bye? Are they beginning to understand what hand gestures are for? Do they make eye contact? Do they turn their head when people call their name? Do they make eye contact when people call their name? Do they enjoy joint activity? Like, do they enjoy looking at a book with a parent? Do they enjoy playing, do they understand kind of peekaboo? Do they enjoy those kind of back and forth kind of games of like peekaboo or something? In pediatrics, usually you're screening, I think, between ages 16 to 30 months using the MChat, more of a formal screener. So that's 20 yes/no questions that you ask. If you have a score of 0 to 2, that's low risk. So if the kid is younger than 2 when you do that and they're low risk, you repeat it, after between 24 and 30 months. If they score a 3 to a 7, that's a moderate risk. And there's like a part 2 of the MChat that's called the follow-up section that you do, or it's you kind of repeat the questions, but rather than yes to no, it's a different component to the questions. And if they score 8 to 20, then they're high risk and you want to send them for an evaluation. So,
hold on.
okay. If you, in terms of some of the components on the MChat that are screening for nonverbal communication is, when you smile, does your child smile back at you? When you look at your child in the eye, or does your child look at you in the eye when you're talking to them, when you're dressing them, when you're feeding them, when you're playing with them? Are they making eye contact? Does your child look or respond when you use their name? Does your child understand, what you're asking, to him or her to do? And then you want to know about joint attention. By a year, normally joint attention is developing. And so that is, ask, like, does your child point with one finger to something they're interested in to show it to you? Not to get food or meet a need, but do they just show you things they're interested in? Like they're pointing at a dog, or they're pointing at, balloon, or just something of interest. And then if you try to get your kid's attention, you're like, look over there at the horse, do they look where you're pointing? Do they just look at you, or do they know to look where you're pointing, right? So that's called joint attention. It's usually developing, at a year of age. So that's one of the ways you can tell that the child understanding nonverbal communication is the smiling, the eye contact, the looking when pointing to show you things, and looking at where you point. On the MChat, some social component items, or does your child show you items by holding them up to you, like, holding you up to show you a truck or a baby doll or something that they like? Do they bring you the item, and not just to get help, like to get the batteries changed, but they want to show you their car because they're excited about it, or it's fun, or do they bring you over things that crinkle or make noise? When something new happens, does your child look at your face to see how you feel about it, right? So you're someplace, a costume party, or somebody, or a birthday party, somebody hires a clown or somebody to come in a Mickey Mouse costume, or you're at Disney World and the characters are coming out. For young kids, sometimes that's surprising when people are wearing strange things or wearing big outfits. So a lot of times kids, look at the parent to try to figure out, oh, what am I supposed to do? Or maybe more common, a child is running and falls. Kids have that moment where they look at their parent to see, do they cry or do they laugh, right? So that's kind of social referencing. So is the child doing any social referencing or not? Does the child imitate parents? Do they, pretend to be talking on the phone? Do they pretend to be cooking or putting in, hammering things, pretending to do things that the parents do? By age, children begin to engage in imaginary play. So they begin to, not just manipulate items, but begin to pretend that a car drives around. So are they doing any make-believe play? Make-believe isn't exactly in the criteria for autism, but it is one of the things we see, that if children are having a hard time getting that, if they're having a hard time getting the understanding of, I'm blanking on the word right now, but if they're having a hard time beginning to understand the representationality of like toys, then they may have a hard time with understanding other people's perspectives, understanding relationships. And very important, I ask this all the time to kids as a screening question, is, do they seem interested in other kids? Typically most of us are wired up to be interested in other people, and especially like babies. So I think whenever I'm at the grocery store, if there's a baby that starts crying, if there's any toddlers in the area, they almost always run over. They talk to the parents like the baby's crying, or they run over and they want to pat the baby and be like, it's okay, baby. And they start talking to the baby, don't cry, it's okay. Does he want my, and some kids will like offer their teddy bear for another kid or something like that. So, and if you go to a playground, most typically developing kids look at the other kids on the playground and want to go over and join. Some are too anxious to join, but they want to go join. So you often want to know, does your kid notice other kids? If you're at a playground and kids are playing, do they want to join the other kids, right? So that's a really important kind of screening question to ask that's on the MChat. Some other things that we see, like in terms of core symptoms of nonverbal communication, other things that you might ask that aren't on the MChat, or maybe the kid is, 3 or 4 and you're wondering, they're new to your practice, you're wondering if this has gotten missed. You might want to know, like, how does this kid let you know what he or she wants? Can you tell what they want? Because remember, on average, right, kids who are 2 use 2-word sentences, kids that are 3 use 3-word sentences. That's very basic communication, right? Mommy, come here, daddy, go, we have cookie or something. Like, they're very simple communications on average. Some kids are very advanced, but on average, a kid uses 3-word communications, but most parents have no trouble knowing what their kid wants, even though the kid's communication isn't very fluid, right? So like, most parents are reading body language and all of those things. So, if a parent says, I don't know what my kid wants, they just cry, they're on the floor, they're having a tantrum, and I don't know what they want, that means the kid may be having trouble communicating non-verbally or understanding the parent's verbal or nonverbal communication. So like, for toddlers, how does the kid let you know what they want? Does the kid ever use your body as a tool? So that most kids, if they want a door open or something, they like put their hand on the door and look at the parent and they go, or in the refrigerator. But if they try to take your hand like it's a screwdriver and use your hand to like extend their hand and use your hand to open the door, that's a more abnormal method. Okay, hang on one second. I think we lost the slides. Get these slides back in place here. Okay, so does the child have echolalia? Are they not really using language fluidly? They're just repeating things that they've heard other people say, repeating things from shows, or TV shows, things that they've heard, right? So sometimes it sounds acceptable at first. If a kid is, using a greeting from a TV show, you say hello and they say, how's it going or something. And then you realize that the kid's saying that all the time. How's it going? How's it going? You ask, what do you want to eat? How's it going? Or whatever. And so they're not really using that language correctly. They're just repeating it. So if kids are talking a lot, but it's really all just repeating things out of context, and that would be a concern. Does the child understand, I, you, and he, she pronouns? Do they understand the concepts of pronouns? Can they say, I want to drink, versus they're saying, you want to drink, when they really mean, I want to drink, because the mom has said, do you want to drink? So are they in trouble with pronouns? Do they refer to themselves in the third person? Kids with autism refer to themselves in the third person because they don't understand the pronouns. So they know that people are getting confused, so they just use their first name. Does it, for a little bit older child even, do they make social chit chat? I always tell the story to my fellows that when I was helping a friend when her daughter turned at her daughter's 4-year-old birthday party, and we had the party and there was lots of presents, and I was kind of, just sitting there helping, and everybody was leaving, and I was sitting with the new 4-year-old. And I said to her, like, well, what do you want to do? You want to play with any of your new toys? And she said, no, let's just talk. And I was like, oh, well, what do you want to talk about? And she's like, I don't know. She was like, I like your earrings. And I was like, oh, my mom gave me these earrings. And she's like, oh, well, my mom gave me these earrings. And my mom gave me this dress. And do you like it? I was like, oh, yes, I like it. It's very pretty. She's like, it's pink. It's my favorite color, right? And it's like 4-year-olds chit chat. Lots of people chit chat, right? And if you don't see a kid like just talking, kind of to talk and just to share, you might be more concerned if that kid has autism. So can they have a conversation with their parents? Or do people feel like the kid just that they feel like the kid just talks at you rather than the kid is talking, back and forth with you? Does the kid have any unusual rhythm or prosody to their speech? Does their speech sound mechanical, sound monotone, sound unusual? And does the kid have any trouble understanding social norms of language? Like what kind of things you say to people, how you greet people, what kind of words you say? Do they ask awkward personal questions when they're at an age that like old enough to know? You don't just say, oh, how much do you weigh, or you're overweight, or whatever. So those might be kind of things you would want to know. Again, for an older kid, if you're not using the MChat, they're past the 36 months, you might want to know, does this kid seem to be content playing alone? Most, when you're around little kids, preschool kids, when your kids are 3 or 4, it's just very hard to cook dinner or do laundry or do anything because they don't have a very long attention span, and they want you to do things with them all the time. Even when they're watching TV, they want the parent to come and sit and watch, like Barney again or Teletubbies, or what Thomas the Tank Engine. They want you to watch it for the 25,000th time, right? You're tired of it, right? So typically developing kids don't tend to just go sit and play with their toys for extended periods of time. So does the kid seem content playing alone? Do they want the parent's attention? Do they want the parent to play games with them? For little kids, do they want to play the tickle game? Do they want you even to watch TV together? Do they want you to come watch and look at their toys? Do they seem interested again in other kids? And then if they're a little older, you might ask, well, what would they do if they're at the playground and another kid came up and said hi? How would they react? Would they say hi back? Would they introduce themselves? You know, some kids with autism like just turn and run away. They might fall on the floor and have a tantrum. You know, like what would they do if another person talked to them? You know, do they know how to play with kids at all? Do they have any reciprocity? Do they eat, you know, kids with autism, you know, sometimes are a little behind, like they might be 4 or 5 and all they want to do is, you know, run around and chase other kids and they're not really having any kind of back and forth or play of any kind. You know, and in terms of emotions, do they seek to share enjoyment? You know, most of us, if we enjoy something, we want to tell other people about it. We want to show other people. It's the reason that we like, if we go someplace and we have great pistachio ice cream, we don't just like enjoy it, keep it to ourselves. We tell all of our friends, oh, this is great pistachio ice cream. You should come with me. You arrange dates to meet your friends there. And you want to know, do you like it? And you try to get people who say, oh, I don't like pistachio ice cream. You try to make them taste it anyway, because we want you to enjoy it if we enjoy it. You know, it's the reason like you go to a movie with people because it's fun to have all the people enjoying it or all the people being scared at the same time, right? That kind of mutual activity. So, you know, does the kid seem to, if they're happy doing something, do they come to get you and they want you to look at it or they want you to try it? You know, does a kid who's 4 or 5, can they read other people's emotions at all? Do they know if mom is angry? Do they know if mom is sad? Do they offer any comfort if somebody's hurt or crying? Do they come over and bring you their teddy bear or bring you tissues, pat you on the arm? Do they say anything to you? If their younger sister falls down, do they pat her and say it'll be okay? Yeah, and then can parents read their kids' facial expression? A lot of kids with autism have very blank expressions or the same expression all the time. They don't seem to know how to mirror their own emotions with their face. So can parents tell if this kid, can they tell if the kid is happy or sad or angry, or do they say like, yeah, my kid looks the same all the time. I don't know what he's thinking or feeling, and I don't know how to read him. Those would all be like different things that you might hear, might ask about if you're concerned about autism, if the parent is concerned about autism. You know, if you get a positive screen, so before the kid is from birth to 36 months, in the state of Florida, I guess anywhere really in the country, if the kid is positive, you would refer them to early steps. You know, I feel like in Florida, this mostly goes pretty well. I know in other states I've worked in, like the early steps was kind of overwhelmed, didn't have enough providers. But I think here in Florida, mostly if they're younger than 3 years, right, we refer them to early steps. There's 15 early steps offices around the state of Florida, and they create an individualized family support plan. They've got a 1-800 number that families can call and get scheduled. Sometimes people go to the house to do part of the assessments, and they will create a plan. You know, typically if the kid is under age 3, that plan might include speech therapy, occupational therapy, physical therapy assessments. It might include ABA therapy. You know, there might be something they might have they help connect the families to providers and give them an idea of like connect them to CARD or to Autism Speaks, or you know, other kind of ways to get information for their kid. And then they will help decide if the kid is going to be qualified to start school-based, school starting at age 3. So the early steps can say this kid, when they turn 3, should have an IEP and they should be getting speech, occupational therapy, autism services starting at age 3 from the public school system, right? If the kid is older than 3, like if the kid is 37 months to 5 years, then you refer them to Child Find to get those same assessments and evaluations. That's part of Fiddlers. You might know it as Fiddlers, and that Fiddlers, so the Child Find would also perhaps give a kid an IEP, put them into, you know, public school, and help get them connected to services like speech OT, all those kind of things. If they're older than 5, then you would if you're uncertain if they have autism or if they somehow need an official diagnosis that insurance wants specific testing or something, you would typically refer to a psychologist who can conduct an ADOS exam with the child. Or you might send them to a child psychiatrist to get like a clinical assessment, right? So autism is a clinical diagnosis. The tests don't say for sure that they have it. Really, the ADOS is just supposed to be taken with the whole history from the parents and the exam of the kid, and given the whole history, do you decide if the kid has autism or not. But the ADOS, and then there's the ADIR, which is a parent interview. Those are considered the two gold standard tests for autism. I'd say they're not. They're really highly subject to the person who's administering the test, their own bias, their own experience. So they are considered the gold standards, but they are far from a gold standard, in my opinion. They're still a bit subjective. So treatment of autism, the core symptoms of autism are all treated through ABA, speech therapy, specialized school services, maybe a social skills group. There's no medication that's been found to be effective for any of the core symptoms of autism, right? So we have no medicines that affect social interactions, nonverbal skills, repetitive behaviors, insistence on sameness, maybe, sensory issues, maybe, but really there's nothing that's been shown consistently to affect those. So you're not going to treat the autism right now with any specific medications. You're treating kind of associated signs and symptoms, right? So half of kids with autism have intellectual disability, which creates problems. So always, if you've got a kid with autism, you also want to screen for intellectual disability. So asking those cognitive milestones. By age 2, does the kid know all their body parts? By age 4, do they know their colors? If you suspect any cognitive delays, you want to get a chromosomal microarray and a Fragile X. I think the American Genetics Association says even if you just suspect autism, get chromosomal microarray and Fragile X to kind of look for anything else there the family needs to be anything that the pediatrician and the family needs to be watching for, as like if they've got any kind of syndrome that might have associated, cardiac problems or neurologic problems or anything else. These kids do have some consistent physical problems. About half have epilepsy, and a number of them, they tend to develop the kind of epilepsy that shows up in adolescence. So maybe not in, pre-pubertal, but more post-pubertal epilepsy. They do have frequent GI problems, frequent constipation, diarrhea, abdominal pain. That's a big problem. Sometimes that's related to restricted eating nothing but macaroni and cheese and chicken nuggets. Certainly can contribute to like intestinal dysbiosis if you kind of follow that kind of a discussion, but they also just seem to have some abnormal motility and a lot of GI symptoms. They have feeding challenges often related to like sensory issues, textures, smells. So some of the sensory pieces about textures and smells, as well as just a really picky palate. So a lot of kids with autism are eating terribly. That can relate to some other like growth challenges and things. So there is I didn't put it in here. There is a company that developed a vitamin for autism. It's expensive. It's probably $70 a month, but if families can afford it, it has some things in it like carnitine and CoQ10, some things that are kind of for neurologic development, but would help. But I think depending on what the kid's eating, they may need to make sure that they're taking a multivitamin or high quality multivitamin, and there is the one that's for autism, which I think is ARNC. Always have to Google it just to see. Let's see. Yeah, it's ANRC. ANRC Essentials comes as a powder or a pill for autism. So common behavior problems are trouble regulating attention, trouble sleep, compulsive behaviors, self-injurious behaviors, irritability, and tantrums, that are problems. Tantrums are certainly affected by a person's communication skills. We see for typically developing kids, a lot of times the tantrums are diminishing by about age 4 as they get much more elaborate in their ability to communicate, right? The more kids can communicate, they can use all kinds of prepositions and adjectives and adverbs, and their vocabulary gets better. Their ability to communicate with their caregivers and people around them creates a decrease in their tantrums because people understand what they want a little bit better. So kids with autism, if they're delayed in their communication skills, then we may have then the tantrums can be kind of related to that people don't know what they want. They're just tantruming and they're not able to communicate. So speech therapy, including like using assisted communication devices, picture boards, all of that may help decrease tantrums. Attention may be just the problems with focus, maybe just problems with focusing in general, or it can be like trouble where they're stuck on their repetitive, restricted range of interests. And so you can't get them to stop with the dinosaurs or whatever it is to be able to focus to try to learn to read if it isn't about a dinosaur. So sometimes it's that they're stuck on their one repetitive thing. Other kids with autism, I've had parents tell me like they just like stare off into space and they don't seem to get engaged in anything. So you kind of want to know like, well, what's the pattern? Because if it's trouble transitioning their attention away from a preferred activity, that's probably better addressed with ABA therapy and shaping their behavior. You know, if you can get that, that's gonna be better addressed by like teaching them that like we need you to do these other things and then getting rewarded for doing the other thing by being allowed to do the repetitive behavior for short periods of time and then having to, go back. And so building their tolerance for not engaging in their repetitive behaviors. That would be better with ABA. But a kid is just kind of like constantly daydreaming, staring off into space. I had one mom who said the kid just stood and looked at the wall and flapped his hands all day and just kind of rocked and flapped his hands. It didn't do anything else, right? That's still, I guess that's kind of still an engaged behavior, but he just kind of looked like he was staring at the wall. Like it was hard to get him to respond to you or say anything. But that's a different kind of animal. You can use medicines that are for ADHD, but understand that the neurobiology, we say that you can diagnose these two things together. We used to in DSM-4 say you could not diagnose them together. Now you're allowed to diagnose them together. However, the neurobiology underlying their attention is probably different. Kids with ADHD have small, unmyelinated brains, more gray matter because they're unmyelinated. They are developing their myelination more slowly. That's the problem. And so they develop myelination and they gain skills. Kids with autism, right, half have a large brain. Half of them have macrocephaly at age 1, partly because they're not pruning their brain correctly. And they also have a lot of their pyramidal cells are jumbled. They're not all lined up neatly. So they have had an abnormality in the way the cells migrated during neural development, and they're not pruning them. So they're different. Small, gray matter, highly gray matter brains, unmyelinated. You did. Sorry, somebody muted me, so I don't know where I got lost. So different pathology. Kids with autism are more sensitive to medicine side effects. So they tend to get more, well, just all kinds of side effects with medicine. So if you're going to give them a stimulant, you got to go really low, really gently, but they often get irritable or they'll have trouble sleeping, something like that. There are some studies, several different studies that show that kids with autism do well on atomoxetine, which is Strattera, and that they have better attention and reduced anxiety. If you're going to start atomoxetine, we usually start at 0.5 milligram per kilogram per day for the first week. And I usually start that with a meal. And then you increase it to 1 milligram per kilogram per day after a week. That's kind of your target dose, 1 milligram per kilogram per day. I usually start it with dinner because the most common problem we have with it is nausea. Lots of kids, about a quarter, are nauseous. And I find that the nausea is reduced if they take it with their largest meal. So it's usually dinner. And then after about 2 weeks, they seem to be acclimated to the nausea, and then you can move it to any time of the day that you want. They can take it in the morning or the evening, whatever is going to be easier for them. Atomoxetine has to be swallowed. It's very, if you open the capsule, the powder is very, very big GI irritant. You really don't want to do that. If they cannot swallow pills, you could try viloxazine, which is Qelbree. But if the kid has Medicaid, you're going to have to do a prior authorization for that and state, what else they've tried or why you aren't using atomoxetine. So you certainly can use stimulants, you can use alpha-2 agonists, you can use atomoxetine or viloxazine to try to help their focus. But you're always going to start low, go slow, because they have more side effects. For sleep, like half of kids with autism have insomnia, so do half of kids with ADHD. So poor sleep is certainly a problem in pediatric practices, and for kids with autism. So you always want to ensure that they have adequate sleep hygiene. We usually want to make sure people have a routine where they have at least 3 steps that are helping them wind down. Sleep experts say you kind of want those 3 steps to be kind of leading you into the bedroom, right? So you brush maybe you have the routine starts with like maybe it's a bedtime snack, brush your teeth, wash your face, change into pajamas, get into bed. We do a story, maybe not snack, depends on the kid. The best studied medication for sleep in kids with autism is melatonin. It's the best studied medicine for sleep in kids, period. There was a randomized controlled trial with 125 kids that were given a long-acting melatonin, and that 69% it was long-acting melatonin or placebo for 13 weeks, and 69% on the melatonin had an improvement in their sleep versus only 39% on placebo. But 40% responded to placebo, so that's kind of cool. The average increase in their sleep was an hour. So you always have to decide if you want to give the melatonin or not. This was with the controlled release, the long-acting melatonin. There was a 2-year open label extension after that 13-week randomized control, and they thought that it was safe. They did not see any medical problems in that kind of time frame or difficulties. It was still effective. Otherwise for sleep, melatonin is the best studied. Depending on the age of the kid, you can use diphenhydramine just like we do for adults. Based on the kid's age, weight, but sometimes some very young kids can get disinhibited with that, so it can be difficult. So most all sleep problems are behavioral. You can get into some other more difficult things or more complicated things for sleep, but overall, we would say melatonin would be the first thing to start. Lots of kids with autism have compulsions, right? And the compulsions, it's often a question of, is this autism? Or people think they have obsessive compulsive disorder because they're doing something over and over again in a repetitive way. And it could be either one. When a kid has obsessive compulsive disorder, typically they engage in the compulsion to reduce a specific fear. So my obsession is I have dirt on my hands, and so I'm compulsively washing over and over to try to get rid of the feeling that my hands are dirty, right? A kid with obsessive compulsive disorder might have to touch a door frame 3 times when they go through it because they are they're worried something bad's going to happen if they walk through the door frame, or if somebody says the word death, they have to repeat some other word in their mind over and over to help make sure that somebody doesn't die, right? So they have a fear and they're engaging the behavior out of a fear, a specific fear, and they are trying to neutralize that fear. Kids with autism in general are doing a compulsive behavior because it's enjoyable to them. It's soothing, it's relaxing, it's comfortable, it's enjoyable. They're shaking their hands because they like to shake their hands. If nothing's going on, they're shaking their hands. They're not doing this because they think something bad's going to happen and they have to somehow stop that. And they're not organizing things because there's a fear that if things are out of order, something bad will happen. They're manipulating things because overall it's enjoyable. Now, if the kid is nonverbal, that can sometimes be hard to sort out. And sometimes kids with autism engage in the compulsive behavior more when they are anxious. So if it happens when they're excited and when they're anxious, it's probably more a stereotype behavior. If they're doing it because you can tell of a specific fear and they're trying to get rid of the fear, then don't do it when they're excited, then that might be more OCD. If they have OCD, that might be more likely to respond to an SSRI, less likely that a compulsion from autism is going to respond to a medication, and you more likely have to do behavioral therapy, ABA, or some kind of behavioral therapy to try to get that reduced. Maybe have it reduction like you do for tics, something like that, but probably a behavior therapy. Going back to the last question about sleep, I don't have any specific melatonin brand that I recommend. Just haven't gone to that. Self-injury, some kids with self-injury, that can be a subtype of repetitive behaviors. Typically you want a behavioral look at that. So whether it's an ABA therapist or somebody at the school or somebody who's kind of looked at the kid's behavior and tried to figure out what are the antecedents, what are the behaviors, what are the consequences? Is there anything sustaining this behavior? What situations does this behavior happen in? What can we do to change the environment to try to get the kid to stop banging their head on the wall or the ground? Or I've seen some really awful kind of repetitive behaviors, kids biting their hands until they are have peeled all the skin off of them, and really awful things. When it's really dangerous, we have to use safety equipment like helmets for head banging, or if the kid who was she really had not all the skin off of her hand. She had like exposed muscle and bone, whatever. We had to like put protective mittens on her, right? The kind that you couldn't get off. Sometimes you have to put kids in a protective suit of some sort. You can try medications, but all the various studies with medications are highly variable. We don't see anything that we consistently can say works for any kind of repetitive behavior, including self-injury. But all kinds of things have been looked at, from omega-3 fatty acids, folinic acid, methylphenidate, serotonin reuptake inhibitors, naltrexone, antipsychotics. Nothing's been consistently found to help reduce repetitive stereotype behaviors or self-injury. So not great. You can try any of them. There's the occasional person who does respond, but there's nothing that we see that consistently works. And then irritability or tantrums, again, thinking about it behaviorally, can we tell what's going on? If it's because the kid can't communicate, speech therapy, picture communication boards, working on communication skills. You might have an ABA therapist doing a functional behavior analysis, or the school might do a functional behavior analysis. And so figure out, do we need to change the environment? Can we train communication? Can we teach replacement behaviors? If the tantrums are related to insistence on sameness, like the kid is having tantrums because something moved in the house, or the bus driver is different who shows up in the bus, or the bus doesn't pull up to the exact spot on the pavement, or somebody, and these kids are often in specialized classrooms and they've got all these other peers that are doing things. So if they're having problems because the other peers can't be in their exact same seats, desks, places, whatever it is, you might try an SSRI, or you could try an SSRI, and sometimes it works. I feel like insistence on sameness, that's a core autism criteria, but sometimes an SSRI will allow them to be just a little bit more flexible and tolerate some deviance, tolerate mom stopping to get milk at the store, even though they might still be agitated about it. They're maybe not kicking mom's seat or grabbing her, pulling her hair, or whatever. Like, they might be able to tolerate a little change in their routine, or some differences in the environment. And the other thing that's approved, the only two medicines that are FDA approved really to treat autism are medicines for irritability that's associated with autism. In the studies, irritability was used as kind of a measure of aggression, which could be self-harm, or could be a harm to others. So that's risperidone and aripiprazole. So risperidone is FDA approved starting at age 5. You usually start at 0.25 milligrams daily, a range of 0.25 to 3 milligrams per day. You want to use the lowest dose possible. So you start 0.25 at night for 2 weeks. Usually only need 2 weeks for either of these two medicines. So in 2-week intervals, you might be increasing the medicine. Aripiprazole is FDA approved starting at 6 years. Usually you start at 1 milligram or 2 milligrams. The range is usually between 5 and 15. Biggest problem with these medicines are that they can cause weight gain. They cause a lot of hunger. You've probably all seen, we can put 20 to 30 pounds on a kid in 30 days. Really awful weight gain for some kids. And that with the weight gain comes abnormalities in metabolic state, right? So blood glucose can go up, cholesterol can go up, kids can develop type 2 diabetes. They certainly get the weight gain and problems with that. So you're supposed to do baseline blood glucose. Usually we do CMP, CBC, lipids at baseline, and then at 3 months, and then at least annually after that. So definitely the risperidone and aripiprazole, with risperidone, you have to worry about breast tissue development, right? You can get galactorrhea, breast milk sometimes, but you also get you just get gynecomastia. And the gynecomastia, as I'm sure you know, is the breast tissue. It's not just the fat. So if kids are gaining weight, sure, they can get fat development, but they can also get actual breast tissue development. And if the breast tissue develops, you cannot reverse that. You stop these medicines, that is not reversed. So a boy who has any kind of significant gynecomastia has to have surgery to correct that. So of course, that's always very unpopular with families. So I usually, try to do a physical exam, palpate the breast if I've got a kid on risperidone, especially for any kid, a boy or girl, but certainly for boys. If the kid doesn't want me to touch them, I'll ask the parent to do the palpation, just palpating over the your nipple, looking for any kind of marble. I tell them, is there a marble shaped feeling? Or a lot of kids just have a lot of tenderness. If they got breast development that's often tender. So if I get the parent or the kid to do the palpation, if they won't let me touch them for some reason, you can check on that. There are a few non-FDA approved substances that have some effect on irritability. So there's been 5 RCTs done with N-acetylcysteine over the counter, and that reduced hyperactivity and irritability. Pretty decent response to the irritability. So it's usually like 600 milligrams twice a day, but it can go as high as 2,700 in a day. So we usually go to like 600 twice a day, give that a try for 3 to 4 weeks. We might go up. Main problem is that you get main problem is they're big pills that are smelly, that are hard to take for a lot of young kids. You can get powder sometimes, and about 30% of kids have GI upset, about 13% have drowsiness. So, but N-acetylcysteine often helps skin picking, nail biting, hoarding kind of things. Sometimes it helps compulsions, and it can help irritability. So we do use it a lot. Families, I put CDB here only because families ask about it. There was one study looking at cannabidiol oil for kids and did not separate from placebo. We don't have any evidence that cannabinoids work for autism, although people talk about it, ask questions about it, but we don't really have any evidence that it works. What we do know for marijuana is that, marijuana seems to worsen attention span, can over a decade reduce IQ by about 10 points, and it tends to cause worsening anxiety in kids. After age 25, after brain development is complete, we don't see that kind of anxiety with cannabinoids, but we know with marijuana anyway. With marijuana, people tend to feel less anxious right when they use it, but then the next day or two they're more anxious, like for teenagers who use a lot of marijuana. So, we're not sure if that's something else in the marijuana or if it's the cannabidiol components. So overall, we still don't recommend that unless you've already tried a whole bunch of other things and you're out of ideas completely. Like if I've gone through 6 medication trials and a kid is seriously hurting themselves, I'm like, okay, you do what you need to, go ahead and try it. But that's not going to be our first line recommendation. So that's kind of what I would say. You screen for autism starting at 12 months with just your normal questions, listening for the things that relate to social relatedness. You should use the MChat probably between age 16 and 30 months, refer to early steps or child find. Usually you're having the kid do speech, ABA, school-based services, no medicines for the core symptoms. You might think about atomoxetine for inattention or maybe stimulants, melatonin controlled release for sleep, risperidone or aripiprazole for irritability. You can always call us at the Florida Behavioral Health Collaborative Pediatric Hotline and talk to one of the child psychiatrists here at USF. We try to get back to you within 24 hours to talk through cases, and that's my email. And certainly there are ways to get a telehealth consult from our services. So let me see. Evidence-based, so looking at the questions in the chat, evidence-based dietary recommendations help with neurologic symptoms. There really isn't that, like, people have done casein-free, gluten-free diets. There are occasional kids that works for. It's less than 10% of kids that have any kind of dramatic response to ADHD or autism symptoms. So in general, if a family wants to do that, it's perfectly fine. I think that the amount of gluten people have in this country, the way wheat in America is harvested using Roundup, it increases the gluten content. So our gluten content's higher than it is in Europe. So, I think overall for families to reduce their sugar content, gluten content for kids can be reasonable, but I don't know that I could, if they feel like doing it, they can manage it fine, but it's not going to be like a dramatic improvement for the majority of kids. So I would just be selective about who I recommend that for. This question in the chat: what tools can a pediatrician use to diagnose an uninsured new patient to demonstrate high functioning autism or to justify services? Well, so depending on the age of the kid, you can certainly use the MChat as a screener. There's the ASRS. There's like an autism questionnaire you can give to teachers and parents and have that kind of scored. So if your pediatric practice, purchased those, you could give those questionnaires to the parent and teacher. I have to double check. I think the BASC has the BASC, BASC. I think that is also something you give to parents and teachers. I think it does have an autism, like it has like a subscale for like depression, anxiety, those kind of things. Think about that. Let me see. because you can get like adaptive functions or like social problems, adaptive functions. Yeah, there's an autism probability index on the BASC. So again, your pediatric practice could purchase the BASC, and the BASC, helps you. You'd have to deal with like language issues between parents and teachers, but you could certainly give it to teachers to see do they have an elevated autism probability. Technically, autism is clinical diagnosis, right? It's supposed to be, did you go through the questions? So, you could document using the criteria that you're documenting: decreased social emotional reciprocity, prefers to play alone, doesn't seek out parents or peers for social activities, has problems communicating nonverbally, has trouble initiating or maintaining relationships, and has these 2 criteria be. You can document, here's the criteria that they meet. Here's these scales that I've given them. You can give an autism diagnosis based just on your clinical interview without even any scales. The problem is not all insurances accept that. But if the kid is an immigrant or doesn't have insurance, then that may not be quite the case anyway. If you're just trying to help the family know what to think about, and help them maybe get connected with Autism Speaks and help them try to find other communities where they can get information, collaborate with other families, get connected, you could do that. Do older teens and preteens benefit from ABA? Somewhat. I mean, ABA, the problem is it's harder to get ABA services for those kids. The services don't always want to work with those kids, mostly because a lot of kids with autism are a bit aggressive. They scratch, they bite, they pinch, they hit. And the bigger the kid is, the more the therapist gets hurt, literally. And so there's some practices that don't want to work with the older kids, but older kids can benefit. You always figure out, what am I working on? So ABA can work on independent living skills. So sometimes I've had teenagers who have autism where the therapist comes in and is helping them learn how to make the bed, helping them learn how to put their laundry in the laundry basket or take their laundry to the laundry room, how to brush their teeth. So they can work on hygiene skills, independent living skills. They can work on practicing individually with an ABA therapist, work on practicing social skills, like practicing going to the store and saying, excuse me, can you help me find the milk, or practicing, all that kind of role playing. They can help them to some extent, practice like with emotions, like what do you do? Like, so somebody made you mad, what do we do? Like, they can help them practice not engaging in a difficult, repetitive behavior. So if a kid's got like a hand flapping thing that's getting in the way of them being able to write or do their homework, like the ABA therapist might be able to help them like time it. Let's try to not do this for 5 minutes and do something else with our hands. And then, give them a reward. So they can help all of that. It's just a matter of finding a therapist it depends on the kid's aggression. It's much harder to do that if the kid is aggressive. Some practices will, but you have to kind of it takes more for the families to find that. Yeah, so if kids are coming up saying, hey, I think I have autism, a lot of times I'm telling them so the ADIR, the Autism Diagnostic Interview, that can be done with parents. It's one of the gold standard tests I told you about, but it's done less often. The Autism Diagnostic Interview is done less often, but that has a way of saying, does the kid have autism now? And did they have it when they were younger? 10% of kids grow out of autism. Most don't, but 10% do. So when they reference anything, they say, okay, between ages 4 and 5, they say to the parent, I want you to imagine the time when the kid was in like a VPK kind of time frame. Where did you live between 4 and 5? Where did you live? What school were they going to? Kind of what was the family household like? At that age, how did they do with playing with other kids, playing with you, seeking out you, social relationships, making friendships, repetitive behaviors, communication? Sometimes you're surprised. I am sometimes surprised when I get a kid that comes to my practice for the first time and they're 12 and they tell me they have a history of autism, and I'm like, they look okay to me, look like they're talking to me okay. But then when I'll say to the parent, tell me about when they were young, and they'll be like, oh, at age 4, no, he wouldn't talk to anybody. He just played by himself in the corner. There was almost no speech. Like, we had to go to speech therapy. He had tantrums all the time. He had no friends. And sometimes I'm like, wow, this same kid who's like playing sports and doing it. So sometimes you're surprised at how they were when they were younger. So if a teenager said, I think I have autism, then I want to talk to the parent and them about, well, what was it like when they were little? Because then again, sometimes I'm surprised. Sometimes I'm surprised at how bad things were when they were young. And sometimes families just aren't telling you that. Sometimes I've worked with families for years. Like I definitely have kids that I've been seeing for years that I think have ADHD or anxiety. They look, and I also just wonder if it's a whole separate topic. I wonder about all kinds of environmental toxins for kids that are driving us, because we never used to see this. That now I see kids all the time in my practice. I've been doing this for almost 30 years. Now I see kids that come in that they look more and more strange as they get older. Like they look by middle school or high school to me, they're having social problems that I didn't so much hear about when they were younger. Maybe I was failing to ask, or maybe, I always ask about friendships and sports and how a kid's doing, but maybe, I don't know whether kids just aren't, our world isn't having them engage with the same expectations. I don't know whether they're just getting exposed to something, but more and more I see kids that by the time they're in middle school and high school, they look odd. And sometimes even kids that I've known for a while, and I go back and I say, in that 4 to 5 year old time frame, how were they doing if you went to the playground? How would they do going up and talking to their kids or playing with kids if they got approached? And sometimes there's just a whole bunch of stuff that I didn't know about because we were focusing on ADHD, and I just, there's a limit to what you can ask people. So unfortunately, sometimes that still happens. But so I think that I would, if a teenager was asking me about it, I always ask, what are you concerned about? Hear about it. I asked a parent about how things were when they were young. And then I explained to them that, a lot of things with autism that people read about, like sensory sensitivities, that can happen to people that don't have autism too. It's not exclusive to autism. So if you have sensory issues, it could be anxiety, it could be personality disorder, it could be depression, it could be many other things. So I get it that you're sensitive and you could still do occupational therapy for sensory issues, but it doesn't necessarily mean you have autism. Yeah, I mean, pediatricians can look at the criteria for autism and make a diagnosis. So the Autism Speaks, it's a little harder to find. I could try to get it to Marie to get it to you guys. The Autism Speaks has some videos of children, like toddlers, and showing how a toddlers that have autism, they compare side by side, a typical kid doing a task and the same kid with autism doing a task. It's a little subtle sometimes. Like sometimes a kid just looks a little bit introverted, but like they'll show a kid something, like you blow bubbles, like you blow bubbles and you put it down. And then a typically developing kid is excited about bubbles. And they look at the mom, they look at the doctor, they look back and forth, and they look at the doctor and they'll tap the bubbles and look at the doctor or pick it up and hold it to the doctor because they want the doctor to blow the bubbles again. The kid with autism just looks at the bubbles and then just looks down, and like they're excited, but they never look at the mom to see if she's excited. They never look at the doctor. They never ask for the bubbles to be blown again. So the Autism Speaks has a video library. I think it's called the Autism Video Glossary. You have to sign up, make a free profile. They don't send you anything. They don't send you any updates or anything, but there is an autism video glossary library that you could look at. Any possibility that pediatrician with some sort of certifications are approved to refer children to ABA? So far, only mental health. I don't know. That seems. I wasn't aware that they require a mental health provider to make a diagnosis. I mean, I guess sometimes the schools will want that to see a mental health provider. And I don't think there's anything, I mean, that's would just be a matter of lobbying those agencies, whether it's the school board, whether that's insurance companies to try to get them to accept pediatric referrals. That's harder, and those are things that if it just need a one-time diagnosis, we have kids that come in for a one-time diagnosis of autism, usually a clinical interview. The problem becomes that Medicaid wants for ABA, they want some kind of ADOS or some kind of specific assessment. That's where you could use the BASC or the ASRS or the Gilliam autism rating scale. For these telehealth consults, we could try to help with that. We could try to, for some providers, we could probably try to do an interview that's around getting a diagnosis of autism. But it's always hard to know whether they'll, even for me, they don't always accept for Medicaid and ABA referral. They don't always accept that I've just done a clinical interview if they want me to get a test, which is hard. Even at the university, it's like 6-month wait for us to get an autism test. It takes a long time. So to get it to do an ADOS. So other questions that folks have? Thank you. Thanks for everybody for listening. Anybody want to have any other questions?
Well, it just left to thank Dr. Stock for really an amazing presentation full of very good tip and information and resources. So we certainly appreciate it. A couple of items. Please do not forget to fill out the survey. It helps us tremendously, and we appreciate it. And don't forget also, we have a Florida or pediatric hotline. Please use it. It's there to help you, and you have a tremendous help from very well-trained psychiatrists, child and adolescent psychiatrists to help you. And then also, don't forget to visit our website. We also have autism guidelines, and we are going probably most likely for sure are going to update them in 2024. So thank you again to everyone for attending and wishing you all happy holidays. Take care all, and thank you